Okay, today we'll be talking about the cardiac cycle uh, under the motto of staying connected in continuation of the cardiovascular system. So, what is a cardiac cycle? Let's begin with a definition because everything needs to be defined and put into specific words that you can regurgitate and understand and explain using the specifics without getting, confused or being confusing. Cardiac cycle is the repetitive cycle of events that include electrical, mechanical, hemodynamic, as well as phonocardiographic. And it seems like the boogeyman or the beast when we talk about phonocardiography, because this is what actually we do when we come to a patient's bedside and ask his blessings to listen to his heart and try to define what is the normal auscultation results that we expect. We've already talked about electrical, and we know that electrical is the conductive system of the heart, being the SA node, the AV node, the rest of the conductive system, the fibers, the speed of transmission, and how we register the conductive system generation of action potential and the spread of action potential is by using the ECG. Mechanical is going to continue because we're going to talk about systole and diastole and the change of pressure and the change of fluid, which is blood, directions inside and outside of the heart, which brings us to the next point, which is hemodynamic. And this is the blood moving into between chambers as well as outside of the heart. I mean, moving outside of the heart, being ejected. And phonocardiography is the sound phenomena. And how do we classify sound phenomena is the topic which we'll be discussing now. But just a reminder is this is the heart depiction, and it's shown that we have the four chambers, the right and left ventricles, the right and left atria, as well as the great vessels, the pulmonary trunk or pulmonary artery, and the aorta. And of course, we have the full cycle of blood going out from the left ventricle through the aortic valve and going to spread the joy and nutrition to all of the body, being deoxygenated, coming back to the right ventricle through the right atria. But you notice that we have the mean pressures that are depicted here as well. And we already know that there is this memorable pressure. It's 120 over 80 being systolic over diastolic. And mind you that when we have a chamber which between a chamber and a chamber we have a valve, or between a chamber and a chamber we do have a valve, we always experience the phenomena of two pressures. That's why we see 120 over 80, because between the left ventricle and the aorta we have the aortic valve. Now the pressure, the blood comes down to the legs and then going up against the gravity and going into the superior and inferior vena cava and going back to the right atrium under the pressure of almost 4, and then it drives into the right ventricle, and the right ventricle, then the pressure is being increased now and is going to pump the volume under the pressure of 25 systolic over 4 diastolic into the pulmonary artery. And now we see that the systolic pressure in the right ventricle is almost exactly the same in the pulmonary artery as well as the aorta and the left ventricle. We see the same picture, almost the same picture, is the systolic pressure is always equal. And I already mentioned that if we have a valve, we expect to see a diastolic pressure. So this is just a reminder of how the pressure changes between chambers and pressure changes between chamber and a great vessel. Because we have a valve, we always expect to see a diastolic pressure. Now, as I already mentioned, when we come to the bedside of the patient and we ask him to expose his chest and we take our stethoscopes, and we lay down the stethoscope on the chest, and we ask the patient to take a deep breath, or exhale and inhale and exhale, and we report to our superiors that we've listened to the chest, and now we have so and so and so and so. What are these results? We have to be very careful so as not to mix them, but if we classify them in a very unique and simple way, we would always know where to begin and where to end. So the classification of the phonocardiographic phenomena, as I like to abbreviate them as PP, heart sounds. Heart sounds include normal heart sounds, which are S1, S2, and S3. And we have the abnormal heart sounds, that is S4 and S3 if it's not heard of from a patient who's a female adolescent or a pregnant female. So S4 and S3, S4 in particular is always pathological, and S3 is sometimes pathological. It depends on which patient we listen for. So the second one is the added heart sounds, and that include the opening snaps, mitral and tricuspid valves, ejection clicks, aortic and pulmonic valves, friction rub, and pericardial knock, and so on and so forth. And the last one, the last phenomena, is the murmurs, and they're classified as systolic versus diastolic. So this is just a broad idea of what to expect when we listen to a patient's heart and how to report that in a way that seems to be more organized. So moving on, when we place a stethoscope on the patient's chest, what we hear is S1 and S2, S1, S2, S1 and S2, and to the human ear, it sounds like lub-dub, 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 lub-dub. And actually, when we hear S1, we denote the beginning of the systole. So when we say S1, that's the beginning of the systole, and S2 is the beginning of the diastole, denoting the end of the systole and beginning of the diastole. So as you see here, the space, the period of time, the moment of silence between S1 and S2, that's what we call systole, and between S2 and S1, that's what we call and we know as diastole. So S1, S2, systole finished, S2, S1, diastole now has begun and finished. So when we say that anything that we hear, anything that happens, anything that takes place between S1 and S2, that is what we know as systolic, and anything that happens between S2 and S1, that's what we call it to be a diastolic. So we can try to memorize it in a more fun way. So between S1 and S2, that's systole. Between S2 and S1, that's diastole. Anything that happens between S1 and S2, that's systolic. And anything between S2 and S1, that has to be diastolic. So S1, S2, tick tock. S1 tick, S2 tock. S1, S2, Facebook. S1, S2, YouTube. S1, S2, Xbox. So it's just an easy way. You can always come up with your version of what happens, what suits you to memorize it better. But for me, it's always in a more musical way, which is of course a music way to understand it. So S1, S2, S1, S2, S1, S2, TikTok, 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 Facebook, 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 or YouTube, whatever version you have, whatever version makes you understand it well or memorize it even. Okay, we're back to this slide again, and we show the phonocardiographic phenomena, and we start commenting about the heart sounds, the S1 and S2, whether or not there is S3 and S4, the pitch, the loudness, and the duration. And then we move on to the next category or subcategory, which is the added heart sounds. And when we talk about opening snaps, that's exclusively about the mitral or and tricuspid valves. Ejection clicks, that's specifically the aortic and pulmonic valves. And then we finally go to the last but not least, the murmurs, and we comment on whether or not we have systolic or diastolic murmurs. And by that we finish the commenting on the auscultation picture of the heart of the patient. We always do it in chapters, we always do it in steps, so as not to forget anything, and we would sound more professional and more understanding of what actually goes on the last uh, uh, tip of the cardiac cycle, which is the sound and the phonocardiographic phenomena. Just to mention a small detail that we can always register anything that sounds, any sound that comes from the heart, be it S1, S2, S3, and S4. We can register it by using the phonocardiograph. But whether or not we'll be able to actually perceive it by our ear, that's definitely dependent on many factors, being the thickness of the chest of the wall of the patient, or the pitch and loudness of the sound, specifically S3 and S4, or even the splitting of S2. But that is for a different segment of this topic, which we will come to understand in it, the genesis and the evolution of the heart sounds.